Good morning, ladies and gentlemen. So I shall be deviating from the topic that we have been discussing so far. So it is on intracorneal ring segments. And as we know that the excimer laser basically flattens the center to correct myopia, the ICRS acts in exactly the opposite way. It increases tissue at the periphery. Now, basically the principles on which this is based is that the posterior compact stroma is not as compact as the anterior stroma, and therefore it can easily accommodate segments. Secondly, the diameter of the segment, that means as far out as you are from the optic center of the eye, you are inducing less correction. So if you're closer to the center, you're inducing more correction. Then again, the thickness of the ring, if you're using a ring with a higher thickness, you're inducing more correction. Now, whenever you have loss of lines because of corneal changes like advanced keratoconus, where your best corrected visual acuity cannot increase beyond a particular point, or you have a very high K dioptric values, the upper limit being around 60 to 70. So earlier it was 60 diopters, up to which you could use ICRS. Now you go beyond. Some people recommend even 70. But the clear central cornea is prerequisite. Also, a minimal pachymetry of 450 microns at the point where you're planning to implant. I'll come to that later on. So, various conditions come under the purview of ICRS that I've mentioned over there, including post-PK, post-RK, trauma, provided the central cornea is clear. Now, you have to be cautious when you're dealing with corneal scars. Any form of corneal dystrophy or any sort of progressive disease that is likely to cause extrusion of the rings, like recurrent corneal erosions, frequent rubbing of the eye, autoimmune diseases, collagen vascular, pregnant patients, and of course, drug intake of drugs that directly affect the cornea. Large pupils you have to be wary in because you're trying to create a flattening of the central 5 to 6 millimeters of the cornea, and people with large diameter pupils may be intolerant to the aberrations that you induce. Endothelial count studies have been done in patients and they have found that the rate of attrition is usually similar to normal attrition to the tune of 1.4 to 1.8% per year. Now, what are the types that we are dealing with? Intacs is one of the most commonly used ones. So here you have PMMA segments that are of an arc of 150. Earlier they used to have wider arcs now, or smaller ones also, but now it's only 150, which are hexagonal or oval in shape more recently, and vary in thickness of 0.5 millimeter steps from 0.21 to 0.5. 0.5 is rarely used. It's basically 0.05 millimeter thickness. 0.5 is rarely used. We use usually up to 0.45. And of course, you have standard and SK variants depending on what part of the zone you're treating. So for standard, you're going far out into the cornea up to approximately 7 millimeters, whereas for SK segments, you're staying nearer the visual axis. Now, Ferrara rings are yellow PMMA rings. They are triangular in cross section. You can see the OCT over there, and they are basically segments which have a prism effect. So the base remains 0.6 millimeters, whereas the height of the ring increases. So that determines the thickness which you are implanting. Now you also have 0.8 segments available. Kera rings are again similar to Ferrara rings, except that they have two more arc values of 150 and 355 microns and wider optic zones compared to Ferrara rings. So Ferrara rings basically treat come at smaller zones, smaller diameters compared to Kera rings. Now that is a point that can be useful for a post-PK patient, usually where the graft is round 8 millimeters and you don't want to encroach on the graft-host junction. Myorings are complete 360-degree rings that can be inserted into the cornea of diameter 5 to 8 millimeters and thickness again varying like the other rings 200 to 320 microns. So they have an upper convex surface, they are foldable, they are they can be compressed and sent in through a small incision to fit an area of 5 to 8 millimeters. So now this is how a Ferrara ring is inserted. After marking the cornea, you are marking the channel and then making an incision with a guarded diamond blade, following which you use a dissector to initiate the channel through which the glide can pass. So once the initial part of the channel is dissected, you can see that circular glide over there. So that creates a whole channel, and you take the segment to implant it at whatever part you have pre-decided according to the myopic correction required and the topography that you want to correct. So now that's a segment going in there. It's a triangular segment that has a prismatic effect. And once it enters the channel, it is positioned to the point, in this case inferiorly, where the correction is required. So here only one segment is being used. Now this is a myoring. So you can see that sort of a lamellar flap-like situation has been created in the cornea, but there are no side cuts. So the only cut is that entry point over there, which is around 5 to 5.5 millimeters, through which this ring, which can be compressed, is inserted so that it enters that intralamellar space, and then it's positioned over the visual axis. The incision is self-sealing. Now, as far as Intacs is concerned, you can do it manually with vacuum to refine. So once vacuum is achieved, you need to pass a glide, a guarded glide at a particular depth that can create the channels. But I use a femtosecond, and I think that's the greatest boon that Intacs has got. So marking of the central cornea is extremely essential. It's not just a simple methylene blue mark, but you need to indent the epithelium a bit, because when you're opposing the cone, you want to make sure that the mark is visible and you're right at the center of the pupil. So now because I've indented the epithelium, I can see the mark clearly. Now this takes, I mean, if you blink, you won't be able to see the femtosecond happening. So it's that fast. And you get all the channel, which is usually at 6. I use the SK most of the time. So you have 6 to 7 millimeters and the incision, as well as the initial beds. Now, again, this is a versatile corneal dissector. You can do both sides with the same one. So you create those small pockets so that passing of the Intacs is easy. Now, one important thing is that when you're taking the initial incision with this dissector, you have to go all the way to the bed, which is usually 30 microns more than the channel that you're making. So that you don't stay superficial. It is bad to stay superficial. It's better you go deeper. But stay within the channel that you have created. And this is an asymmetric Intacs implantation. You can see a 0.45 SK segment going there. And you have to move it slowly, 1 clock hour at a time. And this special instrument that grasps this forceps for the Intacs, it has small curves over here, which make sure that the segment does not slip from grasp. The second thing is that when you're using Intacs or any other ring, it's advisable that you try not to keep it on the epithelium and, get some epithelium and then implant it along with the segment into the channel. So this is a smaller segment. It's a 0.21, which is going into the other zone. And you can see that this being smaller, it passes maybe a bit more smoothly. So these are pre-dissected channels that are expanded because of the passage of Intacs. There are people who recommend that you create smaller channels so that they stay there more tightly. Now, whatever you do, once you pass the Intacs in, you have to make sure that you are using a reverse Sinski, just moving it 1 millimeter away from the incision so that the chances of extrusion are much less. And I always suture my incision. The suture usually comes out, or you need to remove it maybe in about a couple of months, but I always suture it initially. Now, there's some basic rules regarding planning of Intacs. So there's always a nomogram, whichever company you're using, whatever type of ringer you're using. But there's some basic things. One is that if the myopia is high and the cone is centralized, better to use symmetric rings. So for example, in this patient with a central protrusion, you can see the 2.45 SK segments are going, and the incision is usually made along the steep axis. In all 3 cones, you can see that the incision is made along the steep axis. But if the steep axis happens to be at some point where it's hard to maneuver the rings, you can always place it temporally. Now, coming to this patient who has an astigmatic component and there is asymmetry with around 43 diopters here and around 48 over there, you can see that you place an asymmetric segment 0.21 here and a 0.4 over there. In this patient, though there is asymmetry, there is more of asymmetry. So you have something like 42 diopters here and around 50, 54 over there. So you better not put anything on top and put a much steeper segment like 0.45 over there. So you can also implant a single segment in highly asymmetric cases. Another thing you have to note is that it's not the central pachy that is important, but the mid-peripheral pachy. So here there's this patient with a 354 pachy, and here there's one with 315 pachy. Now there's a central pachy, but this patient cannot have intacs because at the zone where intacs needs to be inserted, that is 3 millimeters from the center of the cornea or a 6 millimeter diameter zone. You can see that in the nasal part, the cornea is too thin, it's not 450 microns, whereas on this side, here, though the central pachy is 315, you get 460, 470 microns. So it's the mid-peripheral pachy that's more important. Then visual outcomes are usually fabulous. Now you have to wait long term. There is a bit of regression that happens later on, but immediately the visual outcomes are very, very good, especially with central cones and you're putting symmetric segments. You can see how the astigmatism has become so much more regular, something that can easily be corrected either with glasses or with contact lenses. So these patients who were earlier intolerant to contact lenses get to be tolerant. And the corrected visual acuity improves. So this is a patient with the asymmetric segments. In ASOCT, you can see the difference between the thickness. Then what are the possible complications you can have? Protrusion either through the Bowman's layer or dissection into the anterior chamber. This is usually intraoperative. There can be migration of the ring through the wound that may come out. There can be epithelial ingrowth or infectious keratitis. There can also be some deposits of lipid-like material, especially with thicker rings. There can be persistent pain due to irritation of corneal nerves or persistent corneal edema. But all these are not very common. And with the advent of the femtosecond laser dissection, I think half or more than these complications have been taken off. Now, this has been a compilation of all the studies of Ferrara, Kera, and Intacs. So you can see that the number of complications with Intacs are very, very less compared to those with Ferrara and Kera rings. But at the same time, proper choosing of the patient, proper selection, proper dissection is required to ensure that. Of course, there can be combinations with collagen cross-linking or with multiple types of rings. There are the people who are implanted myoring along with Intacs, and then Intacs with eczema. Though Intacs with eczema should be taken with a pinch of salt is what I believe, because you're already, thinning a cornea which has a ring segment, it's already compromised. So the chances of extrusion of the segment are much, much more. So this was a very brief compilation of, a gist of what to do with Intacs. I hope it's good to get you started. Thank you very much.
Thank you, Dr. Swapna. It was a wonderful compilation, actually. Can we have Dr. Amit